And Amanda Adcock is coming up to speak. She's the nurse practitioner. By the way, she's a certified nurse practitioner. And I don't know if you all know, I find such empathy coming from the nurse practitioners, which is why we love to have them speak. They know so much about your symptoms. They feel like, a lot of times you go to see a clinician that's a nurse practitioner, and you just feel different after you leave there. So we like to have nurse practitioners speak at our program, which is why now we asked Amanda, who's speaking for the first time today. So let's give her a round of applause and thank her for coming.
Hi, I'm Amanda. As he said, Amanda Adcock. I am a nurse practitioner, multiple sclerosis certified nurse practitioner. I work in Coleman, Alabama with Dr. Christopher Legank at North Central Neurology. I have had the honor of having him as my mentor. Very honored for that. I am going to talk today about the invisible symptoms of MS. First, I want to know, is anybody here, when they were a child, did you have an invisible friend? Yeah? Yeah. All right. Did people tell you that wasn't real? Parents, grandparents, that's not real. That you don't have imaginary friends, right? Is that sometimes how you feel about your MS symptoms? When you say you've got this deep burn or this deep itch, no, you don't. There's nothing there. You don't have a rash. There's nothing there. You don't have that. Well, maybe your imaginary friend was not real, but your symptoms are. My friend and colleague, Cindy, sent me this. She is a nurse practitioner with us as well and was diagnosed with MS. We have kind of gone through this journey. I've been there with her. She thought this was very humorous. When she was first diagnosed, we worked together on weekends in the ICU unit, and she started having some tingling around her mouth. Of course, I looked to see if anything was there. Nothing was there. It'll be all right. So we started asking more people, what causes numbness and tingling? We're nurses. We did some research. Low B12. So, okay, we'll get some B12. She'll be fine. As the weekend progressed, more numbness in her chin, in her teeth. By Monday morning when we were leaving work, all the way around her head, completely numb. So first thing she did is went to her primary care doctor. You want to know what he told her? You're depressed. Yeah. You're depressed. Well, we didn't take that answer. We wanted to continue on and look some more. So after he told her, she had just recently been in the hospital for pericarditis before that. That's what she was depressed about. So that's why the side of her face was numb. So we went further. We went looking further. We went to a local neurologist and asked him, to order an MRI because we needed to see what was going on. So we got the call. She said, get straight to the emergency room. You have had multiple strokes. So straight to the emergency room she went. Was admitted and there for 3 days. We were talking, this is not stroke. We've taken care of stroke patients in ICU for 5 years together. This is not stroke symptoms. Maybe, no, that's not it. We've got to keep looking, keep digging. Finally, luckily, Dr. Legank was right across the street. We got her MRI disc, took it to him. Oh, I forgot to mention, she had a lumbar puncture at the time as well. No, it's not MS. It's not MS. So, took him the disc, and sure enough, he said it was MS. Looked just like MS. Along with the signs and symptoms and everything else that we explained, he wanted to see her right then. That was her initial diagnosis. Nobody believed her. Nobody believed these symptoms. Doctors didn't believe these symptoms. So we're going to talk about a lot of these symptoms that doctors can't see, your family can't see. But what I want to get across to you is, something's wrong. You keep looking. If somebody won't listen to your symptom, keep going. Find somebody that will. Find somebody that will help you, because there are people out there that want to help with these symptoms. A few of the symptoms are listed here. We're going to go over. This is not a complete list. I was going over it with Cindy, and she said, but what about this? What about that? And I said, I only have 30 minutes. So this is what we've got. The first, fatigue. Fatigue is the number one symptom that I hear anyway when patients come into my office. about how tired they always are. A different kind of tired. It's not a tired like I stayed up too late and I'm tired today. It is decreased energy on a daily basis, overwhelming sleepiness, sudden exhaustion. You're doing fine 1 minute and the next minute you are so tired you cannot hold your head up. Aggravated by heat or cold, mostly heat intolerance, but there are quite a few that I've found lately with cold intolerance that makes all symptoms worse, fatigue being one of them. Interferes with your activity of daily living. You used to could go to work, come home, make supper, throw some clothes in, do your kids' homework, then stay up for a few more hours and be fine. You're lucky to make it all the way through work these days. That's how overwhelming the fatigue is. Cognitive decline, which we're going to talk about later as well, causes you to be fuzzy. You're tired, you're exhausted, everything's blurry really. You can't even think straight. And then there's muscle fatigue. Your muscles wear out. You used to could shop all day and now you can go to one store and you're done. So what are some causes of this fatigue? There's nothing that's really proven. There's a bunch of theories. Some of them are you use more parts of your brain to do the same task and that the nerve impulses are slowed down. So a person with MS has lesions in their brain. When these signals are running through, they sometimes hit these lesions. They either disappear or they slow down. So something that might take me 30 minutes to do might take you an hour and a half because your brain has to work so much harder and these signals have to go through so many more stop gaps to get to where mine just cruised right on through. You can't ignore other medical conditions that could cause fatigue though. I heard somebody say you can have fleas and ticks at the same time. So that's, you could have MS. Just because you have MS doesn't mean you don't have one of these other conditions. So, if the fatigue is different, if you're experiencing something different than you normally, your new normal, I guess, and this is what Cindy would say, as what your new normal fatigue is, then look into it some more. Try to get some answers. Some of the things that can cause fatigue: anemia, a low blood count, thyroid disorders, hormones, low B12, autoimmune disorders, a lot of lupus, Sjogren's, scleroderma. A lot of the times, these other autoimmune disorders will sometimes cause that same kind of overwhelming fatigue. In diagnosing, we have to rule out a lot of these because they do mimic MS so closely. Sleep problems. Do you have restless legs? Are you moving? Are your legs moving all night? Is that why you're not asleep? Spasticity. Are you hurting all night? Insomnia. Have problems falling asleep? Have problems staying asleep? Or sleep apnea is a problem. Sometimes the medications used to treat some of these symptoms can cause fatigue. You have to kind of weigh the pros and cons there. And then depression. You get a really fine line in between depression and fatigue. We'll go into that a little bit more later. So how do you manage this? Exercise. What? I can't even take a bath. How am I going to exercise? However, studies have shown that the more you do, the more you're able to do. So even if it's a little bit every day, try to get your body going. Try to maintain what you've got, even if it's walking to the mailbox and back. I mean, that's something. Walk a little bit further every day. If it's cold outside or if you're in a chair, do some weightlifting. Do something. Try to keep going, and even though you don't feel like going, it will help. Nutritional intake is always important. Of course, you're eating a meal in a little while, I'm glad I'm not speaking very last because you're all going to be sleepy. Doc gets that. After lunch every day, I call it the dropsies. If I eat lots of bread, high-carb meal, I get sleepy. Same thing with patients with MS. This could be contributing to your fatigue. So watch what you eat. Low carb, low fat diet. That'll help. It's not going to take the fatigue away, but it'll help. Stress management. That's easy to do. Decrease your stress. Not really, but there are relaxation techniques. There's talking, counselors, support groups, things like that. All this are going to take away take away stress, reduce stress, because any stressors on the body is going to inflame your fatigue. Adequate rest, like we talked about, important. Heat and cold techniques to manage fatigue. I have another friend, our kids play ball together. Sometimes they have 2 and 3 ball games a day in 90, 100-degree weather. So she's expected to sit out there because she's mom, and mom's expected to sit out there. And she looks fine. She looks just like me. We, walk around, hang out together. She's not in a chair. Nothing's wrong with her. Why can't she sit through 3 or 4 games? I can. Why can't she? So she's expected to do this, and she tries. But she does have to figure out ways to tolerate and try to manage her fatigue and manage her heat intolerance. A lot of times, right before ball games, she'll either stay in the concession stand, stay in the car with the air conditioner on, something to keep her cool right up until the ball game. And then there's cooling vests. She wears a cooling vest under her clothes. A lot of times you can't even see that. Or the frog togs, the towels that you put around your neck, keep in the cooler. All the boys have them. And she has one too. But so she's learned to manage the heat intolerance. It's things like this that you have to kind of make little adjustments, but figure out what's best for you and how you handle it well. And then there's medicines, the wakeful agents. Wakeful agents such as Nuvigil and Provigil. These medicines are great. They help. They help keep you alert. They help keep you going. The problem with these a lot of times is they are not approved for MS fatigue. They're approved for, I think, hypersomnia with sleep apnea, but MS fatigue, they're not. I wish they were, but they're good medicines. Amantadine. Amantadine was one of the first, or it was the very first medicine for MS fatigue, and it does help. And then there's the stimulant therapy. Stimulants such as Adderall, Ritalin, Focalin, there's many, many of those. There's sometimes a stigma that comes along with stimulant therapy, but if taken as prescribed and for your fatigue, and if it helps you get through the day and increases your activity, helps you be less fatigued, take it. That's my theory. If it helps you, take it. Next, cognitive changes. It goes a lot of hand in hand with fatigue because when you're tired, sometimes you can't think clear. But just in general, even not being fatigued, even with the lesions in your brain, that comes some cognitive fatigue. Usually it's short-term memory that you have problems with. Concentration and attention is different. Information processing. I remember Cindy telling me she could read a page one time. Oh, I didn't mention this. This is very important. She was diagnosed 1 week before she finished nurse practitioner school. So that was fun. We studied a lot. When she used to could retain by reading just one time, we would go over and over and over, which benefited me greatly, but she needed to do it. Planning, prioritizing, things that you used to couldn't do. That you could do, put together a birthday party, a Christmas party like that, no problems at all. Now you're trying to think, what do I even need to get first? Word finding. You've been talking in the middle of a sentence and forgot what you're going to say. I've done it a few times up here, and I don't have MS. But that's a big problem. Sometimes, like I was telling you, those lesions, when your signals hit one of those lesions, bam, gone, lost, whatever you're going to say. Sometimes it'll come back. And I know sometimes it can be embarrassing, and people can look at you like, okay, tell me. Sometimes I tell my patients, make a joke of it. Well, I guess it wasn't that important. If it is, I'll tell you later. Make them laugh. It's not funny, but if you can make some humor out of it, maybe it can take some of the pressure off of you. Daily routines at home and work, like I was talking before, just simple tasks you used to do get harder. Routines at home, there are some things that can help. Crock pot meals. You can go ahead and put a meal in a crock pot, and then that way you can go to work, come home. At least you don't have to do that or think about what you're going to have to cook for supper. You don't have to plan it. It's already done. It's there. That's not something else that's weighing on you or that you'll forget. poor judgment, decision making, and we talked about getting lost in task. So what are some of the causes or management? Infections. If patients come in, or most of the time it's caregivers that will tell me, mom, sister is not acting right. I don't know, she must be getting worse. I think everything's progressing. She's just not remembering things like she used to. She seems very fuzzy. The very first thing I check is a urinalysis. Infections. Infections can cause increased symptoms. It can increase all symptoms. And a lot of times, it is a urinary tract infection. As soon as the antibiotics are complete, mom's back. If you start feeling bad, legs start hurting, start having more cramps, get a little bit foggy, check and see if you have infections. Go to your primary care physician, a sinus infection, a kidney infection, whatever the case may be. Fatigue related, we talked about that. Stress, environmental modifications. This can help a lot of times. You can, if you have problems remembering what light goes to what, label them. Put little labels under. You've got 5 light switches in your house. You have to flip every one every time. Put little labels under them. Label things. Make your everything organization. Organization is key. In the kitchen, are you reaching here and there and there? And by the time you've cooked, you're done. You're tired. You can't even think enough to actually prepare the meal. Just getting it ready. Have everything in order. Make lists. You can make lists. Reminders on your phone. Now everybody's usually got a phone. You can set a reminder. Or alarms to take your medicines. Use friends and family a lot of times. If you can tell your brother, sister, husband, wife, call me, remind me at this certain time, take your medicine. Depend on other people if you can't remember to set the alarm. There's associations or association, repetition, and mnemonics, where you associate, like when you have trouble remembering somebody's name, associate their name with something. And one of my son's friends' names is Bryant. I could never remember that child's name. So he came over one day in an Alabama shirt. And from then on, I associated Bear Bryant, Alabama. I hadn't forgot the kid's name since. Associate it with something. All right, depression. Depression is big not only in MS, but without MS as well. But with MS, it usually at one time or another going to have some depression. Sometimes you don't want to talk about that, but it's important to talk about with your healthcare provider. That way we can try to help you with it. What causes depression? Lots of different things, lots of different theories, different transmitters in your brain. The destruction of the myelin may affect your mood. Lesion placement are the lesions in certain places that cause depression that can affect moods. Is the serotonin in your brain? Is everything, your chemicals imbalanced? Don't really know which one. Is it because you were just diagnosed with MS? That's something you have to deal with. That's something that's, a shock a lot of times. That's something you weren't expecting to handle. It can be depressing, especially if you don't have a support system to help you with it. Sometimes medicines, steroids, interferons, things that are used to treat MS can cause depression. Or contribute, I should say, to depression. Narcotics, pain medicines, other diseases such as hypothyroid and diabetes. This can also cause depression. Pain, fatigue, financial, employment, relationships. A lot of things change for you, not only for you, but for your family and for everybody else. It's a lot to take in. You just want to stay in bed and cover up your head. Not only are you tired and don't feel like doing anything, now you just don't really want to do anything. Some treatment, counseling. Usually multiple treatments are needed. One thing, it's not going to just get rid of it. Counseling, psychiatrist, talk to somebody, your doctor, your friends. support systems, support groups, family. Talk about it, work through it, see if somebody can help you manage it. Maybe you hadn't thought of something that they've thought of. And just when you say things out loud, sometimes it helps. And then there's medication. A lot of times combination therapy is the best, really. Counseling along with some medicine that will help with that. There's SSRIs, tricyclics, and serotonin, norepinephrine reuptake inhibitors is the SNRI. There's newer ones out now that, newer medications out that actually work on 5 receptors. There's some there's Brintellix, and Fetzima is a new one that I prescribe often. Fetzima is a lot of times will also help not only with depression, but with energy. I found in some patients. It's all your body chemistry and your makeup and how it works with you. So you talk to your health care provider about what might be best. Pain. There's pain with MS? Really? That was a big misconception for a while. I even actually heard of doctors saying, no, my MS patients don't have pain. What? What MS patients are you seeing? You know, or have you not taken the time to ask about their pain? You know, there is pain with MS. There's different kinds of pain. There's pain associated with MS, and there's other pain. There's acute pain, which is sudden pain from an injury, from overuse of a muscle. Acute types of acute pain in MS, a lot of times, trigeminal neuralgia, where you'll have that burning, stinging in your jaw, goes to your ear. You can't eat or drink, hot or cold. You can't put your makeup on. It hurts to touch. You can't hold a phone up to it. It's very painful. Those nerves get inflamed. Optic neuritis, about the same. You feel like you've got sand or grit in your eye. You're seeing double. Those are all usually sudden acute types of pain. They don't, last very long, hopefully, but they're there. Chronic pain lasts from 3 to 6 months. Some types of chronic pain, spasticity, stiffness. Spasticity is from stiffness or spasms in the muscles. It's usually caused because of changes in neuron pathways causing the spasticity. There's musculoskeletal pain. Is it because you have a limping gait? You're putting more pressure on this side. Well, you're going to have some pain there because you're getting off balance. Or is it degenerative disc disease because your spine has degenerated and you've got bone on bone and now this is hurting? Are you compressing some nerves there? Any type can be some musculoskeletal. The most prominent type of pain I usually hear with MS is neuropathic pain. These sharp stabbing, stinging pains. The nerve impulses are misfiring, and that's where you get these. So some management. Physical therapy. Physical therapy is excellent, especially if you have a MS certified physical therapist. There are those out there. I don't know if there's any in this area, but they are better equipped to know what tools might help you. There's gait training and balance training. There's lots of different assistive devices now that can help. There's the Bowel, which can help. You put it on your foot and it actually contracts the muscle for you so you don't have to lift it. There's one that you put around your waist and it has a bungee cord type thing to your foot. So not only does it help lift your foot when you walk, but it helps lift your hip as well. So you're not having to use your energy to do that. Other assistive devices such as scooters, walkers, things like that. Exercise, there's that word again, exercise. Yoga, they have some videos and specifically for MS patients. It's a low impact type of yoga that really helps with the stretching and muscle strengthening. We have a lady that comes and teaches yoga to our patients on Mondays at our clinic, and the patients really like this program and it benefits them. Not only does it help with fatigue and energy, it gets them out of the house. So if they're depressed, not wanting to go anywhere, they'll come to the support groups and to yoga. That's 2 times a week that they get out of the house. Very helpful. Acupuncture, if you're not scared of needles. patients have told me that that's helped. It's where they put little needles in specific places, and it helps with the pain. Analgesics, Tylenol, ibuprofen sometimes can be helpful. Antidepressants can be helpful. Cymbalta and Elavil are two that have shown to help. Anti-epileptics, this is for the nerve pain, that burn and stinging pain. Neurontin, Lyrica, Trileptal, Vimpat, those are a few. Anti-spasticity drugs, baclofen, Dantrium, Xanaflex, Flexeril. You have to be careful sometimes. Any of these can cause fatigue to be worse. So kind of, like I said, weigh in your options. There's topical creams. There's creams that have the anti-epileptic and the spasticity drugs in those. You can rub, if your pain's located in one area, then you can rub that cream in that area. And a lot of times those are very beneficial. There's patches. There's lidocaine patches, just completely numb the area. And then there's narcotics. There's short-acting narcotics and there's long-acting narcotics. We generally try, or at our practice anyway, try to go with a long-acting narcotic because it's, well, first of all, it's less abuse, and second, it gives you pain throughout the whole day, pain relief throughout the whole day. Sometimes the short-acting pain medicines, you end up having to take more and more and more because they just don't seem to work anymore. You can build up a tolerance of sorts to those. Bowel dysfunction, that's a fun topic. I'm sorry, y'all are eating. Some types of things that cause bowel dysfunction. Constipation. Constipation is a big thing my patients talk about a lot of the times. Constipation is usually caused by the slowing. Everything kind of slows down. So decreased mobility can cause it. You're not walking around. You're not up moving as much. Decreased intake. You don't eat or drink as much. Or pain medicines. Pain medicines can also cause constipation. The decreased mobility. When I was working in the hospital, after surgeries, our main goal was to get patients up and moving so they'd have a bowel movement. That was the main goal. Because we knew if we didn't get them up and moving, they weren't going to go to the bathroom and they were not going to be discharged. So I know that getting up and moving does help. And then there's the opposite end of the spectrum, involuntary bowel and fecal incontinence. Theory behind that is that electrical impulses to the muscles that empty your bowel can become disrupted, and the signal misfires and you lose control. There's also irritable bowel syndrome. Lots of patients complain about irritable bowel, go back and forth with constipation and diarrhea. Some different management, dietary changes. Increase your fiber, increase your water. Be careful though. If you increase your fiber and you don't increase your water, you're going to have bricks. So you got to make sure to increase your water intake if you're increasing your fiber intake to make everything flow. A regular bowel routine. A bowel routine is important. If you go at a certain time, even if you go and just try, a lot of times that will help get your body more in tune. Y'all probably potty trained your kids, and you always had a time that you told them to go. Just sit there and try and get your body in a routine of doing it. My kids have potty trained or bowel trained themselves because apparently they don't like to use the bathroom at school. I know as soon as we get home from school, they're going to the bathroom. That's their bowel routine, but it's something you get used to. If you can, decrease your pain medicines because a lot of times the pain medicines, like I said, can contribute to the constipation. Increase your physical activity. Get up and moving. Some medications. There's Colace, a stool softener, Miralax, bulking agent, Amitiza and Linzess are two that increase peristalsis. They're fairly new. Increase this peristalsis, get your stomach moving and get things going. Movantic is one specifically designed for pain medicine constipation, for opioids. It is, if you're not taking your pain medicine though, you probably don't want to take that, so because it binds to the receptors. And then this new one I'm not that familiar with because honestly it's just came out, but Viberzi? I don't even know if that's how you say it really. It is actually for the diarrhea with irritable bowel, the opposite end of the spectrum, because some patients have problems with that side. It actually slows things down. So I haven't gotten any patient feedback on that yet, but I'm really interested too, because I'm excited there's finally something out there for the other end of it. Bladder dysfunction. With bladder, sometimes the nerves are damaged that send messages to your bladder muscles, making it hard to control. You might have problems emptying your bladder, you might have problems storing urine, or you might have a combination. Patients complain of urgency, hesitancy, frequency, or incontinence, where the nerve signals are disrupted. So what do you do to manage bladder dysfunction? Kegel exercises. Does anybody know what Kegel exercises are? So do you do your Kegel exercises? I had a test question once. It said, how many Kegel exercises should you do a day in order to strengthen the pelvic floor? Any guesses? How many? It's 100. 100. I thought 100. But that's it. Then I got to think about it. Well, if you do 10 here, 10 there, throughout a whole day, it's not bad. But who's going to remember to do those, right? So maybe while you're watching TV, every time a commercial comes on, don't DVR fast forward through it. Watch the commercial, do your Kegel exercises. There's 10. If you're driving, every time you come to a red light, do your Kegel exercises. There's 10 more. This really does help strengthen and control bladder a lot of the times. Poise pads. A lot of times there's pads there's all kinds of different items that you can get now to help. Different pads, body-shaped pads you can't tell you're wearing. These will help with embarrassment, help with clothes. If you know you're going to be out and away from a bathroom and you do have some leakage. Fluid management, not drinking after about 7 or 8 at night may keep you from getting up and going to the bathroom 5 or 6 times. It might not, but it can't hurt. Then there's the timed voiding, like we talked about with bowels as well. But make sure you go to the bathroom before you go on a long trip or before you get up for a talk. Make sure you go to the bathroom. Then there's the anticholinergic drugs, like the Detrols, Vesicare, and Myrbetriq. There's Botox. Some doctors are doing Botox now in the bladder, which reduces the spasticity. And then there's intermittent self-cath for those that can't empty. Or there's Flomax, which is a medicine that helps empty. All these are specific to patients. You talk to your doctor about them because some can't be taken if you could get pregnant. Flomax is not a medicine for you. Itching. I didn't even know that itching was a symptom. And lots of patients have come in and told me it's a deep inside to the bone. If I could just get something and stick it in there. It's this constant itch. It's hard to explain. Some different medicines to try for those itching, since it's nothing on the outside, not a rash you can put a cream on. Some of the anti-epileptic medicines, some of the nerve pain medicines help. Neurontin, Vimpat, Trileptal, Tegretol, those all seem to help. Sometimes antidepressants will help. Elavil has been shown. And then there are antihistamines, Zyrtec, Atarax, and Benadryl. And again, those can cause fatigue. So, what are the goals of symptom management? To improve your quality of life. That's what we're here for. We're here to help you. We're here to make your life better. To any of these symptoms that we can help, we want to. We need to have achievable expectations. Symptoms might not completely go away, but maybe we can reduce them. Maybe we can make them tolerable so you can do some of the things you used to could do. If that comes in a pill form, so be it. If it comes in an alternative form, from physical therapy or whatever the case. But it's all about working with your physician or with your provider and you to figure out what's best for you and how to make your life better. Because you can deal with this. We can help you. Of course, we want to avoid complications because some medicines lead to more complications. You don't want that. And then, I said eliminate or reduce symptoms. That's our main goal. So, remember when I talked about mnemonics? This is one. I learned this in school, and I thought when Stu came up and showed his paper that you're right on take to the doctor with you, this might be something that you can remember too. This is just a way to remember some of the symptoms and help us help you. If you can tell us, old carts is the mnemonic, old carts. Onset, when did the symptom come on? Did it happen suddenly? Has it been gradually increasing over time? Location, where is it? Is it, your head, your leg, your toe? The duration, how long does it last? Is it those pains that come in and out? They don't last 5 or 10 seconds, but they come 10 times a day. What's the character? Is it achy? Does it burn, sting, sharp? Aggravating or relieving factors. What makes it worse? What makes it better? If you take this, does it make it better? If you move this way, does it make it worse? Does it radiate? Does the pain run down your leg? Does it move across your body? Does it squeeze? How does it move? The timing of it, which is it worse in the heat? Is it worse in the cold? What's the timing? And the severity. How bad is it? Is it 0? Is it a 2 out of a 10? Is it a 10 out of a 10? How bad is it? So that might be a little mnemonic that will help you remember any symptom, not just pain, but any symptom that you have. And I thought this was cute because a lot of my patients sometimes do. I just can't explain to you what's going on. It's just, I'm not going to do it. Well, don't stop trying to explain. Explain the best you can, because if you don't at least try to tell us what's going on, we're not going to know how to help you. And that's it. I made it. I did.
Yay. Congrats to Amanda for her first talk. All right, so we're going to do Q&A for Amanda, and what we are going to do is Ken is going to be on one side of the room. I'm going to be on the other side of the room. Whoever has a question, please hold your hand up. Let us recognize they have a question, and then one of us will get to you. Please remember that we need you to speak into the microphone. Don't push us away, because this doesn't do anything. We need you to talk into the mic, okay? So who's up first? There you go. So that's going to be for Ken, and we're going to flip-flop.
Could you explain again the foot drop device that you were talking about, stimulating the foot when you're trying to walk, or the hip?
Mm-hmm. It's called the Numbness. That's one of, the hip and the foot. The one that was for the hip and the foot, it's called the hip flexor assistive device. It's like a belt that goes around your waist, and it's got a bungee. Have an accident? Okay. It's got a bungee cord type that's stretchy and that goes in it goes into your shoelaces. So when you walk, and it helps, the bungee cord helps pull up, and then the foot comes up with it. It's the hip flexor assistive device. You can look it up, and there's some information on it. Or there's actually one of the videos Stu was talking about. There's a program in Birmingham that he did, and somebody came in and spoke about that specifically. So go back through some of his videos, and it's on there.
Okay. Next question's on paper. Somebody asked about alpha genomics. What can you tell us about alpha genomics?
Well,
I just heard somebody say, "What is that?" So now you got to really explain this.
Okay. There's a new, it's not so new, but not every doctor's office may have it. It is a mouth swab that can tell you what medicine is going to work best for you, or if the medicines you're on are not working for you. Because we have patients come in a lot, they're on 4 different depression medicines, and they're still depressed. Well, we do this mouth swab, send it off. Guess what? None of those were listed on effective treatments for their specific body chemistry. But this other one was. We try it, and it helps. Pain medicines are the same way. And a lot of people just think, oh, they just want more and more and more pain medicines. Well, we've come to find out with some of these mouth swabs that even if they're on 4 different pain medicines, hey, guess what? Those were not going to help them. They need this specific medicine. It's a new test. I'm not real sure what labs particularly do it. We can get some more information on it, though. I think we're going to try to talk to the reps and do a write-up on it, or Cindy is, and put it on Stu's website. So there'll be some more information about it.
Great. Next question is on the other side.
I was going to ask, does your office offer that swab?
Yes.
Can you say that again? What the test was?
Alpha Genomics.
And how do you spell it?
ALPHA Genomics.
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 Alpha Genomics.
I was in the spelling bee.
Good, thank you. Yes, well, the patients that we've done it on, yes. I can't speak for insurances everywhere because I don't know, but the ones that we do it on, it is, yes.
I just want to ask you one question about, we talked about this, the new drug we had that we've been using, and we should be get rid of something sometime. So when it's going to take place? Don't know when. Thank you.
What would you like to know?
Do want to know what's the procedure for all this stuff we're talking about? What am I supposed to use that for?
The one I was talking about for depression and fatigue? Is that what, okay. It was Fetzima. Fetzima it's been beneficial in some patients. Like I said, these medicines aren't for everybody. It's all about your body chemistry, how it works with you. But if you want to ask your doctor about that specifically, it was called Fetzima.
Is it a certain age group when most MS patients are usually diagnosed?
Yes, they're 20 to 40. 20 to 40 usually. Of course, we have quite a few pediatric patients, and then we have many over 40 as well. So it's kind of when I guess you get to the correct physician that's going to diagnose you, but normally 20 to 40 is the age that most are diagnosed. Yes, ma'am.
I was just going to add that in our group, we're coming from Montgomery, and we're part of a group there, and we had a group member that was 8 that had MS. So I just wanted to.
Yeah.
Definitely. We've got some patients that are, 8 and 9.
I have a question from somebody that wants to know how to increase their appetite.
How to increase the appetite?
Increase the appetite. He's having a hard time.
There are medications that are specifically designed to increase your appetite. Let's see. Megace is one.
Okay. You have a question there?
What's the difference between pediatric symptoms versus adult onset of MS?
I think everybody is different. There's, in general, every MS patient, pediatric or adult, there's different symptoms. There's not really, the onset's not the same in anybody, whether it be age, race, gender, there's not specific signs like that I know of anyway.
Another question handed to me. These people don't want to talk, all right? Here's a good one for you, though. They want to know what they could do to increase sensitivity for sexual dysfunction.
Okay, that's one of the symptoms I didn't talk about. Cindy got on to me, sorry. But you could go into that all day. There are, sometimes you can use some of the anti-epileptic medicines to increase sensation. Sometimes the male medicines like Cialis and Viagra will help if you have decreased sensation.
That's it about that? I thought that would be a long subject. We all do
It was one question.
We all do want it longer, right?
It was one question.
Okay, here's another question back here.
What about the MS hug?
The MS hugs.
Yes.
It's where you get that squeezing around you, different parts. A lot of time, anti-spasticity medicines help with that. Baclofen, I find, is a good one that will help with the hugs. It's because it's spasticity is what it is.
Any other questions? If there's no more questions, then we have to give a round of applause to Amanda for coming down today.
Thank you. Thank you, Stu, for having me. I appreciate it.
I think she did a great, great job. I can't wait to have her speak again.